Ready? Okay. Yeah.
All right. Good morning, everybody. Welcome to Cardiology Grand Rounds. So I am delighted to be able to introduce Dr. Sadiya Khan, who is our Trailblazer visiting professor this year. As you will all remember, our Trailblazer Award is for a visiting professor who is a rising star in the field of cardiovascular science and academic cardiology, and we couldn't have done it better this year with Dr. Khan. She's a cardiologist and the Magerstadt Professor of Cardiovascular Epidemiology at Northwestern. She's a nationally recognized expert in cardiovascular epidemiology and preventative cardiology, and we're honored to have her here at the University of Washington. She has distinguished herself through groundbreaking research at the intersection of heart failure, population health, and cardiovascular risk prediction. Her work, spanning large-scale epidemiologic studies, precision prevention, and deep phenotyping for heart failure, has won her awards. She's been widely published. She's well-funded by the NIH and runs multiple R01s and a U01. And her leadership goes beyond that. She has leadership roles with the American Heart Association, and she speaks widely on a range of topics, and we're really delighted to have her here. So, Dr. Khan, thanks very much for joining us. We're looking forward to having you meeting with people today and looking forward to your talk this morning.
Wonderful.
Yeah.
Thank you so much for that very kind introduction. And really a privilege to be able to be here and share with you all a little bit about prevent and risk prediction. What Greg didn't mention in his introduction is apparently I also win the award for cheesiest titles possible. So I will try to live up to that with as many mom jokes as I can through the rest of this conversation. I have no relationships with industry to disclose. So I'm going to start with perhaps a little bit of a fantastical question. Can you imagine a world free of heart disease? It may seem aspirational, it may seem almost not possible, but I'll argue this is the frame with which we want to start talking about as we think about public health and prevention. Because if that isn't the goal, even if it feels not achievable, then I think we're going to fall short. I'm going to start with a story, and you may wonder why is someone who's here talking about prevention going to talk about sudden cardiac arrest, but I promise it will make sense a little bit. But this actually was a story that happened to me a few months ago when I was boarding a plane. I had a passenger that said, "Help, I think the person next to me is having a seizure." And as you can imagine, because we're at Cardiology Grand Rounds, it was not a seizure, but it was a sudden cardiac death event. And the person was pulseless. We started CPR. We delivered a shock with an AED ×2, and we got return of systemic circulation. Now, this person had a lot of things going for them, including the fact that there were 3 physicians who had boarded this plane in the first 10 people boarding the plane, which is just probably totally random luck, especially when you think about the fact that all the out-of-hospital cardiac arrests that happen, maybe 500,000 in the US every year, 90% are fatal, right? People don't even get back to the hospital alive. So this person was alive, had a pulse back, was speaking to us, and we hadn't left yet. So got to the ER and to the cath lab within 30 minutes of this arrest. O'Hare is also situated very close to a hospital with a cath lab. So all of this to say, what did I say when I saw this event and was part of this event? Was this a preventable event? Did we already know there was something here that we could have done? And was that something that could have actually changed the trajectory of what happened before he had his MI? And it's not, as much as we think about this in prevention, it's not uncommon, right? Work done by Neil Chatterjee here has really helped to highlight that almost half of people who have a sudden cardiac arrest event don't have a known history of cardiovascular disease. So was there something that we should have known or done? And I'll tell you, as I started to speak with him, this guy was 69 and he had chronic kidney disease. So he had 2 risk factors, and I don't know if he was undertreated or overtreated, but it did kind of start making me think, was his predicted risk of cardiovascular disease before this event on the plane high enough that we could have done something, especially if we thought about chronic kidney disease as a risk factor? And third, what evidence-based therapies could he have been on to reduce his risk of CVD before and now after, hopefully as well? So with that framing, I'm going to go into kind of the outline for what I want to talk about today and think about how we move forward in terms of our larger goal of prevention. So first, I think to be able to understand where we're going for prevention, we want to describe the evolving burden of cardiovascular disease and its subtypes, and data from IHME and Greg's team have really helped to highlight how we can better understand this. Second, talk about contemporary and emerging models for risk prediction of cardiovascular disease and its subtypes. And third, talk a little bit about the path forward, and love to hear kind of conversation and discussion about how we do this. How do we improve risk assessment? How do we optimize prevention? And how do we make a difference? So getting started, I think we have to really begin at the beginning of cardiovascular epidemiology, and really just a few decades ago when the president passed away suddenly from a stroke. This was the headline in the St. Louis Post. Came out of the clear sky. Now, we know that wasn't the case. And if you look at some of the blood pressure tracings, I love this New England Journal paper because the historical perspective here is just incredible, right? There were clear signs. He had heart failure. He had chronic kidney disease. He had elevated blood pressure that was untreated. But that was the current state of clinical care, right? So when we put that in perspective, in the 1940s, there was this really emerging epidemic of heart disease deaths, and that was the rise of cardiovascular disease as a leading cause of death because communicable diseases were getting managed and people were living long enough to have heart disease. And at that time, Dr. White, who is probably one of the fathers of the American Heart Association, was quoted to say, we know hypertension may be an important compensatory mechanism, which should not be tampered with, even where it's certain we could control it. And so I bring this historical perspective because I think we've come so far in terms of thinking about how low should we now treat? When do we start treatment? When do we think about prevention? And kind of think about continuing to push that needle as we think about optimizing prevention. Oh, I don't know what that is from, but maybe I can, how do I get back to the screen? There we go. Sorry, I'm so not tech savvy. Ah, thank you. Okay. So at that time, and I really kind of love thinking about the beginning of cardiovascular epidemiology with Congress starting the Framingham Heart Study, and when risk factors themselves were coined, and this really led to the first risk score that exists in terms of the Framingham risk score. And what we see in the following several decades is this progressive decline in heart disease mortality. Now, if you're from the Framingham Heart Study, you might actually say that it was because of the Framingham Heart Study that we saw this favorable progress, but I think it's probably many different things in terms of really understanding prevention and treatment as well. Are we good? Awesome, thank you. So what happened as we fast forward a few decades later? Well, the 21st century really brought continued declines in ischemic heart disease, right? We knew that we had statins, we knew how to revascularize people, we knew how to treat ischemic heart disease. But what we saw was a shifting subtype and a reversal to age-adjusted mortality rates for heart failure going up and persistent racial and ethnic disparities across the United States. Now, we can have a little bit of a discussion about whether or not these numbers are accurate, given that heart failure coded as a cause of death is a questionable thing, but I think it's really to bring about the concept and the point that we're shifting the type of cardiovascular disease that we're dealing with, and so prevention also has to change from that perspective and lens, that we can't just prevent ischemic heart disease if we want to prevent cardiovascular disease and its burden. So it's not a surprise to anyone listening, to anyone in this audience. Why is this happening? Why are we seeing a reversal, plateau, reversal, upswing in cardiovascular mortality? Well, cardiometabolic risk is going up. We know rates of overweight and obesity are increasing, rates of hypertension and poor control are prevalent, rates of prediabetes and diabetes are on the rise, and all of these contribute to chronic kidney disease and cardiovascular disease. So how much does this drive cardiovascular deaths? Well, a lot. If you look at the deaths per 100,000, and these are data that are freely available from IHME because of Greg's team, all the work they're doing, that really helps us see, well, we know that overweight and obesity are contributing to a majority of cardiovascular disease deaths, hypertension, prediabetes, and diabetes. And so in aggregate, you can explain most of cardiovascular disease mortality. So it is in fact preventable. We know what the key risk factors are. So what do we do about it? Even more concerningly, we're seeing increases in the rise of these risk factors for young adults. These are data from NHANES that were published a couple of years ago that show that the prevalence of obesity and diabetes have increased significantly among young adults. So individuals under the age of 44, where we don't generally think about risk prediction and prevention either, but we're seeing growing burden. And if all of that wasn't disappointing enough, when you look forward, if current trends continue, what do we see moving forward? The American Heart Association published these forecasting estimates saying that by 2050, 61% of US adults will have obesity, 81 million people will be living with diabetes, and we're expecting $1.8 trillion in projected healthcare spending by 2050, which doesn't even seem sustainable that we would make it to that point. And so this is a wonderfully AI-generated image of a growing tsunami of cardiovascular kidney metabolic syndrome in the US, where we're seeing this really growing burden, and maybe we're just in the beginning of what is going to be a wave of overwhelming chronic disease that's coming. So all of that, I hope I have thoroughly depressed everyone here and pointed out that we're heading for, a dismal future, is not quite without hope. And so hopefully in the next segment of this conversation, I'll convince you that the potential for changing that trajectory is never been greater than it has been today. And that I think we have the opportunity at this inflection point to really make a tremendous impact. So the first thing that all of this came together and highlighted was that we really need a new prevention paradigm. What we're doing has worked, but it's actually insufficient. And we need to think more broadly, particularly around this complex interplay of metabolic disease, chronic kidney disease, and cardiovascular disease that often co-occur, and think about how we're going to treat these patients together and think about that synergistic relationship. We know that there's higher risk when people have multiple conditions. So if you have diabetes and CKD, your risk is much higher, and you're going to have cardiovascular disease at an even younger age. But I think the hopeful part is that we've never had better scientific understanding of the underlying pathobiology of these conditions, what connects them. We have novel therapies. I think the number of trials that come out every day is overwhelming. And for the fellows in the audience, I don't know how to keep up with it. So it is overwhelming. But it's also really incredible to think about the evidence for the multi-system impact of these therapies. We're no longer studying diabetes drugs for their hemoglobin A1C lowering. We're studying them for their benefit on kidney disease and cardiovascular disease. And we're thinking about cardiovascular therapies for their benefit on kidney disease. And so I think it's really, really a wonderful opportunity to think about this. And all of this came together about 2 years ago in the new cardiovascular kidney metabolic syndrome construct that was commissioned by the American Heart Association to say, how do we actually bring this together? How do we provide a conceptual framework that allows it to be more comprehensive and cohesive and holistic rather than just kind of kidney patients going here and heart disease patients going here and prevention kind of sitting in the middle of all of this? So cardiovascular kidney metabolic syndrome was defined as a health disorder due to connections among heart disease, kidney disease, and obesity that lead to poor health outcomes, and led to these two scientific statements that really define this conceptual construct. And I think what we did was really pull from the heart failure guidelines and the staging idea to say, how do we identify people across progressive stages that increase risk? And that really underlied the next part of what I'll talk about, which is the fact that risk is such a central part of this conversation. When we think about people that have risk factors, that are developing risk factors, that have subclinical disease, how do we actually quantify their risk and consider what the risk factors are that contribute to that? So this will transition to the next segment, which is to talk about how we think about risk prediction and how we can do it better. So Predicting risk or risk prediction has been around since probably Framingham was first created, and this is ubiquitous in all of clinical medicine and in our daily lives. I mean, we look at the weather forecast to decide if we need an umbrella. Well, most of us do, not the people in Seattle, because you always take an umbrella and it will always rain. And I think it hasn't rained yet today, but it will. But in clinical medicine, what we're trying to understand is, can we identify who are the patients that are at higher risk so that we can take a risk-based approach to prevention, with the goal to match the type and intensity of interventions with the predicted risk. So we're not treating everyone, but we're trying to find out who would most benefit from that treatment with a risk prediction tool. And this has become commonplace in all of our guidelines and has been endorsed in the blood pressure guideline and the cholesterol guideline and primary prevention, and most recently, a couple of years ago, in the heart failure guidelines, as well as thinking about this importance of quantifying risk with multivariable risk tools. But all of these recommendations really rely on accurate and precise risk prediction. And the question is, are we there right now with what our current tool or contemporary tool is with the pooled cohort equations? And when we met a few years ago to really start talking about this, we said, well, we think there are some gaps. And then we did a gap analysis and said that really there are 3 areas that the pooled cohort equations suggest do need to be updated, because we don't want to just create a new risk score for the sake of creating a new risk score, but do we really need one? And I think these 3 domains, thinking about the population to be studied, the cardiovascular, kidney metabolic burden, and thinking about the life course approach with younger people being at risk, really suggested that we needed new risk tools. Specifically, the generalizability and the contemporary nature of data inform the risk prediction model. It's only as accurate as the diversity of the sample that it was derived in, and ensuring that it includes modern data given changes in risk factor and treatment patterns. The growing cardiovascular kidney metabolic burden that I shared means that heart failure has to be a part of this conversation, and we can't just focus on ASCVD alone. And we have to think about predictors that are relevant to social risks, to kidney risks, to metabolic risks as well. And third, think about the time horizon that we're dealing with. 10 years may be really short for someone who's young. And if we think about the growing burden in young adults, how do we better include that group into risk assessment tools as well? And so with that, this amazing group came together, and it was really a privilege to be part of and work with some of the brightest minds in thinking about cardiovascular epidemiology, cardiovascular medicine. We had pediatric specialists, we had clinical specialists to really come together and say, how do we do this? And how do we build a better tool and not just reinvent the wheel? So this led to a scientific statement and a methods manuscript that I have listed here that really helped to detail some of the conversations that we had, and I'll hope to give a little bit of insight around some of what we talked about and compress that into a much shorter period than the 2 years we spent talking about this, and felt like sometimes we were going in circles, but I think at the end came to some important conclusions. So first, I'll start with an overview or a summary of what's new in PREVENT, and I compare and benchmark to the pooled cohort equations and the older Framingham risk score here, because I think it's helpful to show that sequential progression over time, in that none of these risk models are really that different. They're all trying to accomplish the same goal with populations that are relevant to the target population of interest. So thinking about, who was included in the Framingham risk score, to the pooled cohort equations, to the PREVENT equations, there's a lot of overlap, and it was just growth over time with more contemporary data. The predictors, traditional risk factors haven't changed. They are still the most relevant and important factors that are included, but including and adding to that, thinking specifically around kidney function, the higher prevalence of statin treatment, and hemoglobin A1C, and a social factor with social deprivation index. And then the outcomes of interest moving from coronary heart disease alone to coronary heart disease and stroke, and now to more a composite cardiovascular disease. So how did the models perform overall? Well, shown here are for the 3 separate outcomes that we studied: total cardiovascular disease, atherosclerotic cardiovascular disease, and heart failure, the number of events by sex, as well as the C statistic and the calibration slope. So the C statistic gives you a bit of a rank ordering, where 0.5 would be the flip of a coin and 1 would be perfection. So pretty good in terms of the 0.7 to 0.8 range. The calibration slope gives you the observed to predicted ratio. So close to 1 is perfect, and we see close to 1 pretty much across the board for these equations. So I wanted to spend some time talking a little bit about the analytic questions that went into development. And I think these are some of the areas that I get asked about the most in terms of why were these choices made and what do they mean and how do they support the validity of the tool and perhaps its use in clinical practice. So I broke this down into 3 key questions that I think are relevant and perhaps important in thinking more broadly about risk prediction tools, whether for cardiovascular disease or not. Specifically, what are the data sources? What are the best predictors? And how do we ensure a race-conscious lens as we think about moving forward with cardiovascular disease risk prediction? So first, in terms of the data sources, I have listed here for the derivation, we use both research cohorts and electronic medical records. And so the research cohorts were not something that were new. That was something that had been part of the pooled cohort equations as well. We added in a few more cohorts that had been used there. But the real strength of the evolution of the data came from the ability to leverage a large number of patients from both Geisinger and Optum to say that we have contemporary and modern data. And these are the same patients that we want to be treating as well. So we can include the people in the development that are those then going to be used. One of the advantages of being able to do it in this way was really to explode the sample size compared to what had been done before and what's feasible with just using research cohorts alone. So this is a little bit of a comical graphic of the number of people drawn to scale that were in the Framingham risk score pooled cohort equations. And then PREVENT, just to highlight that being able to access electronic medical records meant that we could really expand the number of people being included and therefore have a more generalizable model because it was really reflective of the US population. What did that mean in terms of the baseline characteristics? So was it really representative of the US? And I think overall we did a reasonable job. We had a mean age in the 50s. We had racial and ethnic diversity. We had an average blood pressure, diabetes rate, statin rate, and kidney function as we would expect in the US population. The other thing that's really important in thinking about the data sources are the temporal evolution of these risk models. So in the first panel, I have the cardiovascular disease mortality rates that span the period of time that these risk models came from. And then in the second panel, I show the time period that each of these models are based on. So not just necessarily who are the population or the patients that are being used, not the size of the patients or population being used in each model, but how relevant is it to the time period that we're in today? Now, in order to have 10-year models, you need at least 10 years of follow-up. But when you look at the pooled cohort equations and realize that the majority of that data came from the 70s and 80s, even though the model was published in 2013, and you look at the mortality rate in the 70s and 80s to where it was in 2013, there's a 50% change, right? We've actually made a lot of progress, even though the beginning of this talk was about how we're undoing all that progress. So it really set up this question of, are we overestimating risk today with the pooled cohort equations? And so then how does the PREVENT equations compare to the pooled cohort equations? So if we take the same number, same group of people that we had in the PREVENT model performance, and the top is that table that we just looked at for how well the PREVENT model did, particularly for ASCVD, and then we look at it for the pooled cohort equations, well, based on what I just told you, you're not surprised to see that the calibration slope is 0.5. So in the same person, if I were to put in all my risk factor levels, which maybe aren't as good as they should be, but if I put that into the calculator, the number that the PREVENT equation would give me is going to be half that what the pooled cohort equation is going to give me. And that I think is really important as we start thinking about the context of what do we do with these numbers and how do we interpret them as we change our frame of risk prediction. What about the risk factors that went into the model? Well, I told you that the traditional risk factors were retained in the model, but one of the key conceptual things that we really wanted to anchor on when we were having these conversations was we want to make sure the model uses routine clinical data so that we're not creating an entire new paradigm of new biomarkers needing to be tested or different variables that are not accessible to primary care clinicians, that are not translatable to the general community. And so that was really where the concept of the core base model came from. But we also realized that there are other important variables that matter, particularly in subsets of patients with chronic kidney disease, with diabetes, patients who may have different social risk factors. And so how do we conceptualize that? And we came up with this add-on model. Now, I'll argue that we maybe added a lot of complexity by doing it this way, because I think there's 36 different equations that you could use for any single patient that you're seeing, which perhaps is not the most translatable approach. But if we think about the base model as the first place to start, these optional models were really developed to try to think about ways that we can refine risk in specific populations. In particular, we really wanted to make sure we incorporated this emphasis in chronic kidney disease, and work by Dr. Bonsall here has really helped to highlight the importance of chronic kidney disease on cardiovascular disease outcomes. And you'll probably be familiar that the pooled cohort equations don't incorporate chronic kidney disease parameters, yet we know that patients who have lower GFR and more albuminuria have more events. And so I think this is just a really striking bar graph when you look at the number of events and that fourfold higher risk for heart failure, coronary heart disease, stroke, sudden death, like the story in the beginning. We know that this is a really important patient population that needs to be incorporated into our risk assessment and prevention strategies. Work from the CKD Prognosis Consortium has also helped to emphasize that continuous and dose-dependent nature. So it's not a dichotomous, yes, you have CKD or you don't, but the actual eGFR and UACR in terms of the cardiovascular mortality and heart failure outcomes shown in these two heat maps is higher, with both factors being higher, and both factors are important, which was an important discussion point. Do we include GFR because that's what's routinely available, or do we have UACR? And we settled on this add-on for UACR because we also wanted to highlight the awareness of measuring UACR, which I think probably less than a third of patients who are eligible for UACR monitoring get it routinely, particularly among patients with diabetes, yet there is this dose-dependent relationship with outcomes. The third thing that I'll touch on is really this, probably one of the most difficult and challenging conversations that we had around how do we ensure that we focus the model on the factors that matter and not the surrogates. So self-identified race and ethnicity has become a really important perspective in how we approach clinical care. There was the New England Journal of Medicine paper. We had a conversation with the National Academies of Medicine where we presented PREVENT to them as well, and talked about this discussion of how do we make sure that we capture the fact that individuals who are Black in the United States have a much higher rate of dying from cardiovascular disease, and yet not embed that into the model to infer that there's a biologic causal factor from race itself as well in how we think about this. And so the way that we factored this in was thought about incorporating a social factor, and the one that was most widely available was the social deprivation index. One of the important conversations, and this is work from Nilay Shah at our institution, who's a junior faculty, was to look at the factors that actually explain racial differences. And so this is work from the coronary artery risk development in young adults, or the CARDIA cohort, where he asked the question, we know that Black adults in the CARDIA study have an over twofold higher risk of cardiovascular disease. So that's that first line in both women and men. But if you adjust for the clinical factors, and I think that second model is really important, so blood pressure, BMI, diabetes status, CKD status, you actually mitigate the racial difference. And of course, this goes back to even more upstream social factors, structural and systemic racism, that make those factors more prevalent as well in Black Americans: higher rates of hypertension, earlier age of hypertension, worse outcomes with hypertension and diabetes. But it really started to think about this question of, well, if we know that these differences in cardiovascular disease outcomes translate into the differences in cardiovascular disease that we see, well, can we actually capture that in the model if we have a diverse sample without embedding race into it? And these are data from the PREVENT tool in NHANES, looking at each race and sex group by age, and shown here just for men. And you see, again, a 20 to 40% higher predicted risk without having race in the model, suggesting that we're capturing a lot of it. Now, I don't think we're capturing all of it, because of course there are other factors related to racism, lived experience, and other social factors that aren't getting embedded into traditional risk factors, but we're capturing a lot of that risk. We all know that geographic patterning of social determinants of health matter. And this is a figure where we looked at 3 of the cities in the United States that have the highest life expectancy gap. In Chicago, I think we're infamous for a 30-year life expectancy gap across an 8-mile radius, and that is my commute to work. I cross this western side of Chicago to downtown Chicago, where the average life expectancy goes from 60 to 90. And you can see that it's very geographically patterned across the west and south side of Chicago in the first panels there. And it's patterned by social vulnerability. And so this is not a surprise to say that areas that have lower median income, that have higher vulnerability, are the same areas that have a higher proportion of individuals who identify as Black living there. I really thought this quote was something that resonated a lot with me. I was reading this book, Under the Skin, that talks about the fact that Black Americans live sicker and die younger. And Linda Villarosa, who's really just a stunning writer and worked for the New York Times, has this one quote that I think is really important, because over the course of the last year, as I've been talking about PREVENT, I've heard a lot of people say, well, you replaced race with SDI. And I think that is not at all what our intent was. And I hope I convince you that that is not what we're trying to accomplish with having a social factor in the model. And her quote is, if you really care about these issues and want to make a difference, you must not use race as a proxy for poverty or poverty as a proxy for race. They intersect and overlap, but to really understand the health of this country, you have to be more sophisticated than assuming that only poor Blacks are affected by this crisis. Look deeper and think differently. And I think this is just really, really important as we think about the different things that affect people and their lived experiences, and particularly related to the current political climate of what are the factors that contribute to health and health outcomes. It's much more than just one thing. And race is not monolithic. And so having that perspective, I think, helps in terms of how we interpret those disparities as well. So how did we do in terms of racial and ethnic differences with PREVENT? I showed you that there are racial and ethnic differences, but I also think it's important to say, were we well calibrated across groups? And did we actually do a good job when we look at each of these groups? And you see here for Asian adults, Black adults, Hispanic adults, and white adults, the calibration slopes are actually fairly spot on. We see it be around 1 for each of them. And when you compare it to the pooled cohort equations, you again see that overestimation with a slope of about 0.5 for each racial and ethnic group. So in fact, we did move the needle for both of those things. We've also done some work since in terms of looking at racial and ethnic differences in the VA, which is another large population of individuals who are at very high risk of cardiovascular disease. And you see in the first 2 panels, PREVENT does a good job at predicting cardiovascular disease and does a similar job across race and ethnic groups. And pooled cohort equations overestimate risk there as well. We've also seen work that has come out from the Kaiser group in Northern California that has a sample that's very enriched specifically for Asian individuals, and again shows that PREVENT model in the blue and the purple does a really good job at predicting cardiovascular disease risk, is on par with the K-PAR model, which is the developed model there, and does better than the pooled cohort equations. One of the conversations we've started having is, can we actually build this out more globally? And is there a global implication to having a single or unifying risk prediction model? And we've done some work with the Korean population looking at whether or not PREVENT does a similarly good job at predicting cardiovascular disease. And what you see here is in women, it looks like it does, but in men, there seems to be an overestimation for heart failure. So I want to transition to kind of the third part, which is what is the path forward to improve risk assessment and optimize risk-based prevention, and where do we go from here? The calculator is available online. So this is the QR code, and that hyperlink also has R code and Stata code for anyone who's interested from research perspectives. We're working with Epic to integrate it into EMR. So that is also coming in terms of clinical usability. But there are some questions that I think are left. And so this is really probably the next 3 most common questions that I get asked. Well, what about biomarkers? We know a lot more today than we did a couple decades ago. So should we be thinking about those? What are the risk thresholds? I think I've convinced you thoroughly that you're going to get different risk estimates today for a patient with PREVENT than you are for pooled cohort equations. So how do you interpret that? And third, we started to talk about this conversation of longer term risk, but what does that actually mean and how do you use it? So in terms of biomarkers, we've done some work with polygenic risk scores, with coronary calcium. This is a table that has summarized the actual reclassification that you get with a lot of these biomarkers. Other than coronary artery calcium for ASCVD, you don't get much benefit. Now, these are older models with Framingham and pooled cohort equations, but we don't really see much benefit for atherosclerotic cardiovascular disease yet. I think we know what the risk factors are. Cholesterol, blood pressure, diabetes risk plays such an important role for these factors that it's really hard to move the needle without an imaging test of subclinical disease, which you could argue is actually the disease itself rather than the prediction tool. Now, where I think there is opportunity, and Greg introduced my interest in heart failure, so I might also be biased in saying that I think heart failure is where there is opportunity for biomarkers to have a role. And data from observational cohorts have highlighted how important BNP and high sensitivity troponin are in associations with disease, as well as in really changes in discrimination with change in C statistic and that reclassification, both of which really show that you can move the needle on risk prediction with these biomarkers for heart failure. So perhaps an opportunity where we could think about earlier detection of pre-heart failure or heart failure with these biomarkers in place. But I think we still have work to do before this could be routinely used. And that was our biggest hesitation in pulling in anything that wasn't already routinely being measured. The second most common discussion that I have is that of risk scores and risk thresholds. So risk scores are the model you use to develop a risk estimate, but then what do you do with it? And I think thresholds are really the important piece where you think about how do you actually use that model and what do you do with it? And of course, with any change in a risk model, especially one that is going to dramatically give you a different risk estimate, well, how do you now interpret it? And so this was a viewpoint that we published in JAMA just a few months ago to really highlight how do we interpret the change in prevent risk estimates compared to the pooled cohort equation. And I want to really highlight one of these points, which was the foundational principles that were developed in the 2013 guidelines remain relevant. So we can predict risk now with more precision, but the number itself is different. And so to determine what to do with that number, we should go back to how that decision for 7.5% was made. And I get asked this all the time, well, how are we going to do this now with 7.5% if your number is so much lower? Well, 7.5% actually came from the fact that they knew pooled cohort was overestimating risk. So the threshold itself being set at 7.5 took a look at the moderate intensity statin and high intensity statin benefits. So if you assume that the relative risk reduction of moderate intensity statin is about 35%, and that for high intensity statin is about 45%, and if the proposed harm is incident diabetes at 1% over 10 years for moderate intensity or 3% over 10 years for a high intensity statin, well, you can see that that threshold probably could be as low as 3%. But it was set at 7.5, knowing that you're probably overestimating by twofold. So I think we can actually go back to the numbers themselves and think about what that new threshold should be. More importantly, statins aren't the only thing you're going to use risk thresholds for anymore, I don't think. We've got really multiple new classes of therapies, but particularly for cardiovascular disease and CKM syndrome, I think these three are the most promising for SGLT2 inhibitors, GLP-1s, and non-steroidal MRAs. But how we define the thresholds for when we use these, if we go beyond just disease-specific indications, I think has to depend on that risk benefit, that where's that line between which benefit and harm can really come out. And in order to understand that, I think we need to actually take a look and say, well, how many people are eligible for these therapies? I thought this was a really kind of nice modeling exercise in NHANES saying if we look at all of the people who are eligible for GLP-1s based on a weight management indication, based on CVD, based on diabetes, well, it's actually a lot of people. I think the final estimate was something like 130 million. Well, of course, not everyone's going to get everything. And I think this movie was just like a very resonant title for me. If you think about all those therapies that are now available for prevention, well, we don't want everyone getting everything all at once. So how do we actually decide this? And I think that's where risk and benefit can play a role. So not just risk alone. This figure kind of highlights what the difference in people who have different baseline predicted risk is going to be for their benefit. And then I'll make a comment a little bit about cost. So if you look at the person in the red, that person who has a higher baseline predicted risk for the same relative risk. So if the therapy has the same relative risk, no matter what your baseline is going to have a greater absolute difference or benefit in treatment than the person in the green that has a lower predicted risk, right? That's just the math of absolute risk times relative risk for what that absolute risk reduction is. But I think it sets up an important conversation that we know that people who are at higher risk are going to have greater absolute benefit and maybe have a more cost-effective approach to therapies, whereas lower absolute risk is going to have limited benefit on an absolute scale, even if they get the same relative benefit, and it may not be cost-effective. So I think we have to figure out what those thresholds are, but that may be an important way to think about therapies as well. Of course, all of this relies on guidelines, and I know you have wonderful people here like Chris who are on the Joint Committee, as well as Catherine who leads the Joint Committee on Clinical Practice Guidelines, but that's where we're really, I think, able to put this together. So I preempt all of my talks now with this slide to say I don't have any answers, but we need the ACC/AHA clinical guidelines to tell you how to interpret and implement PREVENT. And good news, they've released that the blood pressure, cholesterol, and CKM syndrome guidelines will be coming out in the next 12 months. So I think we'll have a lot more answers then. I just wanted to touch briefly on 30-year risk as well, because that was part of what we wanted to do. And we put out these risk estimates, but we don't necessarily know how you interpret them or how it might help patients. And I want to point out that the 2019 guidelines actually recommended this. They suggested that for people 20 to 59 years, 30-year ASCVD risk may be considered, but they didn't actually say what to do with it or what to do with those numbers. And so we recently published kind of an overview of saying, what's the distribution of PREVENT 10-year and 30-year risk? And not surprising, most people that are at higher 10-year risk are at higher 30-year risk. The math works that way, right? You have the same risk factors that go into both equations. But the thing that we wanted to point out was the discordance. So about 1 in 7 people from 30 to 59 have a high 30-year risk, greater than 20%, who have a low predicted 10-year risk. And that probably tracks with age because you haven't had enough time for all that cholesterol and blood pressure to marinate to cause high 10-year risk. And you're not going to have an event in the next 10 years, but thinking about the longer term matters. So I wanted to conclude with a few thoughts of where are we going, and perhaps maybe this can be some of our conversation. And what we really need to do, a risk model by itself is not going to change population health. It's not going to improve prevention, but it's the implementation. And so how do we integrate with electronic medical records? How do we think about appropriate nudges? How do we communicate in a way that patients understand and appreciate what they should be doing and what these thresholds are? And then where do we go for risk prediction in general? Well, I spent a lot of time talking about the general population, but I think underrepresented or risk-enriched groups are really important. HIV, rheumatoid arthritis, adverse pregnancy outcomes. These are all areas where I think we need a lot more work. ML has really exploded. I think it's probably the biggest buzzword of the current, era, but can it be helpful? We have really incredible amount of data from omics, images, wearables. Will that help? Thinking about dynamic risk prediction, how do we incorporate longitudinal data? This is one snapshot in time to get to risk, but people's risk factors change. Does it matter if your blood pressure goes up, if you gain weight, if you lose weight, and how does that change your risk? So I'll conclude with these 3 steps that I think will help bring us closer toward a world of ideal cardiovascular, kidney, metabolic health. First, it's important to recognize this growing burden of CKM syndrome, which threatens to reverse progress, and particularly in young adults who often aren't coming to the doctor and aren't getting routine preventive care. Second, PREVENT accurately and precisely predicts risk for CVD, ASCVD, and heart failure, and includes predictors and outcomes that are relevant. And third, I think the future is very bright, but we need more external validation. We have to think about how social factors contribute to cardiovascular disease risk, and how do we actually use these models for risk thresholds for the therapies we have. And so thank you so much for your time and attention, and I'll leave you with this quote.
Thanks, Sadiya. That was a whirlwind tour. That was really great. I'm glad we have time for questions.
Okay.
I'm going to take the first one, though.
Please.
So everyone think about your questions while I'm asking. If you're going to predict out to 30 years, and you're going to argue that that is clinically useful, then you have to grapple with treating people earlier. Unless you're aware of a behavioral intervention that we're not, pharmacotherapies are going to form the basis of what you're going to do, which makes me want to know how young we should be treating people. Right now, there's a broader focus on chronic disease, but there's also a big backlash against pharmacotherapies. And I'm just curious, when you see people in clinic or when you think about it from a research perspective, how young should we be starting pharmacotherapies?
Yeah, no, it's a great question. And I think, well, I'll start with the people I see in clinic, I think are a very select group who have sought me out to get preventive care. But there's a lot of young people with high blood pressure, with diabetes that are seeking preventive cardiology care. So I think that perspective maybe biases me a little bit because they want to know more information. And I do think the current kind of direct to consumer era, whether it's for genetic testing or polygenic risk scores, or you could go get your CT done for CAC by yourself, right? Like this idea that we're shifting into more information can be helpful if it can motivate change. So I guess I would say I'm not sure that 30-year risk is really to say that someone should or shouldn't be treated, but can it be adjunctive information from a communication standpoint for adherence to medications? Half of people with diabetes don't take their medications. Half of people with statins who are recommended therapy don't take them, right? So is there perhaps a different frame that it can be useful? Now, I will also argue, though, that I don't think, even if we don't yet have behavioral interventions that have been proven to be effective and sustainable, that isn't actually another goal, that it doesn't just have to be pharmacotherapy from it. And maybe I'm too optimistic that has to be an answer, but I do think that has to be a focus if we want a sustainable change in cardiovascular health.
Yeah, Jake.
I have an add-on question. Regarding, thanks. Regarding statin therapy for young patients, how do you think about the possible increased risk of diabetes? You mentioned it. Because if you don't think that there's a long-term downside of statins and you have a motivated patient who's 25, 30, 35, family history, and there is going to be a benefit long-term for cardiovascular disease, if they tolerate the drug and they want to take it, I don't see a reason not to prescribe it. However, if you really believe that there's an incident risk of diabetes and maybe long-term dementia risk, then that's a different equation. So how are you thinking about that right now?
Yeah, it's a great question. I think, well, I'm going to separate the diabetes harm and the dementia harm because I think those are two very different outcomes. The dementia harm has not been consistently shown in randomized studies. And so I think that one I'm going to leave aside because I don't know that I think the evidence supports that. And that's generally what I say to my patients is we know there have been anecdotal reports saying that there may be cognitive decline, but we don't see any signal for that. And in fact, there may be benefit if you think about vascular dementia being a really major component. From the diabetes harm, do I think it's real? Yes, I think the cholesterol treatment trialist data really are convincing to show over a 10-year period about 3% incidence rate of developing diabetes. But were they probably going to get diabetes anyways? That has been the general argument, right? Like it's a delta of 0.5 in the hemoglobin A1C between people who were on statins and who weren't on statins. And I would even go one further to argue, isn't it better to have just shifted your A1C by 0.5 and have had a 30 to 40% reduction in cardiovascular disease events? And so I think, yes, I don't think that harm itself should preclude treatment, but is more as a kind of a floor for where on a population level, we may want to think about what's the right threshold. Now, if you look at a lot of modeling studies, you could argue based on cost of statins, even counting into that harm, universal treatment of statins, I'll be provocative, is not a bad idea, right? Will we as a society ever accept treating everybody with a drug? Probably not. But to your point, the motivated patient in front of you that's asking about what they can do, I think it's very reasonable to say that you could lower your risk with this, but your absolute benefit on the short term may be low.
That was just a fantastic talk. I just want to follow up on your comment about people that seek you. I think I was very struck by the graph that you showed, the biggest benefit from the higher risk. I guess that's the issue with access and things like that. I mean, I was in clinic yesterday afternoon and I had somebody for prevention that came, and that person is at very low risk, but the people who are at the high risk never come to us. I mean, they rarely come to us. So can you comment on what can we do as cardiologists, as healthcare systems to capture those people? Because I think that is the main problem that I see in my clinic.
Yeah, it's really just, I think, a great question in terms of what is our responsibility as clinicians, as health systems, and in society of changing who comes to the doctor, who has access to the doctor, and perhaps is changing every day right now in terms of who will have access to insurance and high quality care, to your point. There was a really nice paper in JAMA Network Open maybe a year ago that showed the number of declines by insurance for cholesterol testing in US adults. So a third of people had their coverage for cholesterol testing denied. So I think until we fundamentally change our healthcare system, I don't think there is an answer to your question other than what are strategies outside of the healthcare system. So I think barbershops, churches, community organizations, and partnerships are how we collectively can make this better, but I think we have to change our healthcare system.
Chris.
One of the very common travelers, one of the very common travelers, co-travelers with CKM syndrome is atrial fibrillation. And I'm wondering, is there anything that we know about AF as a risk marker and how it might play along with some of the other well-established risk factors and modifiers that is useful?
Thank you, Chris. That was a topic of a lot of conversation actually when we were defining the outcome was, should we include atrial fibrillation in our outcome? So in the CKM construct, that first figure that I showed, it is included in stage 4 CKM for that reason, right? Totally super prevalent, becomes increasingly more prevalent with the other risk factors that you have. But our biggest challenge with incorporating it into the risk prediction algorithm was that it's not well defined, it's captured erratically, and the therapies that may prevent ASCVD and heart failure are not the same that prevent AFib as far as we know yet. And I think that's where, if we're better able to understand what's on the road to preventing AFib, or do we just need a separate AFib risk prediction score, I think are definitely opportunities. But I should have known you'd ask about AFib. Is it important? It's probably not important. A little bit. Okay.
I have another question.
Yeah.
Polygenic risk scores. I don't think we can let you escape without asking. A lot of progress being made in that area. And when you think about this kind of life course perspective, like what's more life course than, identifying these risks that are, well, I won't say they're not modifiable because we may have the technology to modify them, but are identifiable at a much earlier age. Do they have a current role? And then separate from that, is there a future role that you can see where those are important?
Is this being recorded? No, I'm
Yes, this is being recorded.
Just kidding. Just kidding. So it's a super controversial area, right? So do polygenic risk scores help in terms of risk prediction, as well as is there a role for them in clinical care? And is that role particularly relevant in young adults? So I guess I'll break it down into 3 parts. I think we know from the available data that polygenic risk scores, which are essentially just a mathematical model of all of the common variants that are built into populations, can be associated with cardiovascular disease and predict cardiovascular disease. But from all the data that we've seen, they don't do that much better than the traditional risk factors. And that's the challenge, is how much incremental benefit do you get from an additional marker or biomarker, like, whether you look at troponin or polygenic risk scores or BNP for ASCVD before it's worth implementing. And then I think the follow-up challenge to that is, if it were a biomarker like BNP that we knew how to measure and there was only one gold standard and we knew what high was, I think it'd be a little bit easier to say, well, it's more information. But turns out there was a paper in JAMA just a few months ago that showed that if you look at the 40 polygenic risk scores for ASCVD that are published or for CHD that are published, they all give you 40 different results. And in fact, 80% of people that would be high risk in one are low risk in another. So how do you interpret it, or which one do you use? And until I think we have one model that says clinically you should use this one, and then high is this percentile, and this is what we should do then with that information, I think it's a little bit of a tough spot. Now, you made the same point about 30-year risk. PRS may be more motivating to people than 30-year risk. So I think there may be an opportunity to say, if this helps you stay on your therapy or do some sort of behavioral intervention, then I think it's useful. But even in young adults, we looked at Framingham Heart Study participants, and 30-year risk was not that different than PRS, even in the 20 to 39-year-olds. So I think there's still a little bit of question of how much is better and what motivates people to change and whether or not you know what high is.
Great. Well, let's thank Dr. Khan for just a great talk. Really appreciate you joining us. Looking forward to you visiting with us today. Thanks again.
Thank you so much.